Hello and welcome to our webinar, Conducting Remote Assessments for ASD using the Vineland-3. Our presenter today is Dr. Celine Saulnier. We have Dr. Anne-Marie Kimball, Dr. Selena Oliver, Chris Uzenik, and Aaron Gunnelson from Pearson with us today, and they will monitor the chat box. This webinar is being presented in broadcast audio only. Please turn up your computer speakers to hear the audio. If you're having any connectivity issues or audio issues, please click on the question mark at the top right-hand side of your computer screen for assistance. Please type any questions that you have into the chat box. We will answer questions live, time permitting. And all of you can download the webinar handout and CE forms under the Event Resources tab. A half hour after this webinar concludes, you will also be able to view the webinar recording with your login from today. With all that being said, I will turn it over to Dr. Anne-Marie Kimball.
Thank you, Sherry. I want to introduce our author today, Dr. Celine Saulnier. Celine Saulnier is a PhD who obtained her doctorate in clinical psychology from the University of Connecticut, after which she completed a postdoctoral fellowship and then joined the faculty at the Yale Child Study. At Yale, Dr. Saulnier worked closely with Drs. Ami Klin and Sarah Sparrow investigating adaptive behavior profiles in ASD. In 2011, she relocated to the Marcus Autism Center and Emory University School of Medicine to help develop and direct a large-scale clinical research program. In June 2018, she left Marcus to develop her own diagnostic clinic and consulting company, Neurodevelopmental Assessment and Consulting Services, but remains an adjunct associate professor at Emory. Dr. Saulnier has written 2 books, Essentials of Autism Spectrum Disorders Evaluation and Assessment, and Essentials of Adaptive Behavior Assessment of Neurodevelopmental Disorders, and is co-author of the Vineland Adaptive Behavior Scales 3rd edition. So welcome all of you, and welcome Dr. Saulnier. Thank you for being here.
Thank you so much, Anne-Marie, and welcome everybody. I really appreciate you taking this time out of your busy schedules to attend the webinar. I do have to disclose that I receive royalties from Pearson and from Wiley, and also I can consult on clinical trials that use the Vineland as an outcome measure. And you have your learning objectives, and as mentioned, you'll receive the slides at the end for download. I will probably go through some of the slides more quickly just so that we have ample time at the end for questions and discussion. Given the topic, I would imagine that a lot of people will have some questions. So just quickly to go over the diagnostic criteria for autism, we're talking about a neurodevelopmental disorder that is a social disability first and foremost. So we need to identify the persistent deficits in social communication and interaction, both currently and by history. The DSM allows you to check off those criteria if it's one or the other, but we really want to determine if these symptoms are present in early development. The other core symptoms are the restricted, repetitive, and stereotyped behaviors. These can be your motor mannerisms like hand flapping, finger fanning, posturing fingers, or full body movements like body rocking, jumping up and down, spinning. Then you have your need for sameness and excessive adherence to routines. You have your circumscribed interests and perseverations, so getting stuck on a topic or on a thing or object. And then you have your hyper and hypo reactivity sensory input. So individuals need to have at least 2 of these restricted and repetitive behaviors, either currently or by history. Symptoms do have to be present in early childhood, even if you're not identifying them until later in life. I evaluate many adults for the first time, even those who are self-referring for an autism evaluation, and it's very important to still determine if their early childhood was marked by any of the symptoms according to the disorder. So I will always ask if there's a living family member, a parent and or sibling, a cousin, aunt or uncle that knew their early development well. And then symptoms, of course, have to cause clinically significant impairment across areas and not explained by another disability, which is why we'll talk in further detail about the importance of the developmental and or cognitive assessments. So what I like about the DSM-5 are the clinical specifiers. So this really helps to inform treatment and intervention. So when I come up with the diagnosis and I say, yes, this is an individual with autism, that really doesn't tell me much about the individual's profile. So the specifiers really outline that. First and foremost, do they have accompanying developmental delays or intellectual disability? Right here as a specifier, I'll just say whether or not it's cognitive impairment or cognitive delays. But if I actually am diagnosing comorbid intellectual disability, I will use another diagnostic code for that, so that I'm giving autism as one code, but also intellectual disability. Same thing with the speech profile. Here in the specifier, I'll say this is a child who's nonverbal or minimally verbal, or maybe they have echolalic phrase speech, or maybe they have fluid sentence speech. But if they have an accompanying communication disorder, I will give that a separate code. And then there are now over 1,000 genetic mutations associated with autism and hundreds of genetic disorders. So if we know and can identify the genetic disorder, I will put that here in the specifier, whether it's 16p11 or 3q29 or 22q or whatever the associated genetic condition. That's important to know. And then with the DSM-5, we can say whether or not autism is co-occurring with ADHD. If it is, you want a primary diagnosis and a secondary. It really depends on the presenting symptomatology. I will give both diagnostic codes, but I will list here in the specifier that there's comorbid ADHD. And then there is research to show that catatonia can be present in some individuals with autism. We usually see these symptoms in later adolescence and or adulthood, so it's important to note here as well. Then the severity levels for autism, you're going to give to both the social communication impairments as well as the restricted and repetitive behaviors. And the severity level is based on how much support the individual needs. So if they're more socially motivated and reciprocal but still have autism, maybe I'll give them a level 1 for social impairments. But if they're restricted and repetitive behaviors are so all-consuming that they get in the way of everyday functioning, I might give a level 2 or a level 3 for restricted behaviors. So you can change those depending on the presenting symptomatology. So every other year, the Center for Disease Control and Prevention puts out the epidemiological statistics on autism. And in 2020, the current prevalence rates for autism are 1 in 54 individuals in the general population. So that's almost 2% of the population. Now, it's 4 times higher in boys than girls. There's a lot of controversy on what the diagnostic presentation looks like in females, particularly females who do not have cognitive or language impairments. And we could have a whole discussion on that. So just knowing that their presentations can be quite complex. The median age of diagnosis in our country is 4.5 to 5 years of age, even though we can reliably diagnose autism at 18 to 24 months. So that's at least a 2-year gap between when we know we can make a diagnosis and when we are making a diagnosis. And then if we're looking at disadvantaged communities, racial and ethnic disparities, for example, African-American, Hispanic children can be diagnosed later, and sometimes, 7, 8 years of age rather than 4, if they're ever accurately diagnosed at all. And then about 1/3 of individuals who are diagnosed with autism will have comorbid intellectual disability. And thankfully, we're getting better at identifying children with autism prior to the age of 3, but we still have a long way to go. And because it is a highly genetic disorder, we'll see higher rates of autism in siblings. So if a family has one child with autism, the likelihood of having a subsequent child with autism is no longer 1 in 54, it's 1 in 5. And then another 1 in 5 siblings will have what we call shadow symptoms of autism, meaning they have some of the symptoms, but not enough to meet full criteria in the DSM. So we call this the broader autism phenotype. And then another 1 in 10 siblings will have some developmental concern, whether it's a language delay, cognitive delay, or both. And so roughly 50% of siblings are going to be vulnerable in their development in some way. When we look at the autism spectrum, a lot of people talk about the spectrum based on levels of functioning, quote unquote, whereas high functioning really means people who have autism symptomatology, but intact cognition and language. And then lower functioning autism, quote unquote, tends to be those that have comorbid cognitive and or language impairment. When you look at individuals with autism who have cognitive and language impairment, they're more likely to have medical comorbidities, things like seizures, cardiac defects, other medical complications. Whereas when you look at the end of the spectrum of individuals with intact cognition and language, they may have more insight into the nature of their disability, so they're more aware of their failures to navigate the social world. And that's when you can see higher psychiatric comorbidities like anxiety and depression, and even suicidality. So when we're conducting an evaluation for autism, it's very comprehensive and it's multidisciplinary. So I am a psychologist. I can only do so much of the evaluation with my expertise. So I will always be looking for an experienced speech pathologist, an occupational therapist, a developmental pediatrician, a child psychiatrist, an adult psychiatrist. So just know where your limits are and when you need to pick up the phone and contact someone to flesh out the profile. So we'll go through these different components. So my fellow psychologists out there, you know that we're usually doing the baseline of development and or cognitive functioning. We're also potentially looking at memory skills, some neuropsychological skills, motor skills, play, social cognition, and adaptive behavior. So first and foremost, we want that baseline of cognition. And so in the DSM, we're looking at defining intellectual disability as having both cognitive delays, roughly 2 standard deviations below the mean on a standardized measure of cognition, and deficits in adaptive functioning in at least 2 areas of communication, daily living or personal skills, socialization skills, and independent living. Notice here that the DSM does not have motor skills, adaptive motor skills, as one of those areas of delay. What changed in the DSM-5 that I know in my own experience people have had a hard time transitioning with are the severity levels of cognition. When we used to determine these based on IQ number, so mild intellectual disability, for example, was having an IQ between 55 to 70. We are now keying these severity levels into adaptive functioning or level of independence. So I want to bring your attention to a wonderful article and give credit to my colleague Audrey Thurm at the National Institute of Health for bringing it to my attention. This article by Mark Tassé, where really looking and determining these wonderful benchmarks for severity levels of intellectual functioning based on adaptive behavior. And he throughout the article, if you look at it, he does the lifespan. So you see early childhood, going into adolescence, and then going into adulthood. You have your severity levels of mild, moderate, severe, and profound, and then by adaptive area, by practical skills, by conceptual skills, and socialization skills. So it's just a wonderful metric to use to identify those benchmarks, and they could change throughout development. So now that we have identified the cognitive profile, we now want to identify the adaptive behavior profile. And to differentiate these constructs, think of cognition as one's repertoire of optimal skills, right? What a person is capable of performing or their abilities. Adaptive behavior is how you take the skills that you have in your repertoire and you apply them to daily contexts and routines with complete independence. So it's not what a person can do, what they're capable of, but rather what a person does with complete independence when life demands the behavior. That means no prompts, no supports, no help, no reminders. So how are we going to survive in the day-to-day world on our own? So the characteristics of adaptive behavior, it's age-related. There are different sets of adaptive skills you would expect a toddler to have versus an adolescent versus an adult. They're defined by the expectations and standards of others. So that we'll talk about the clinical interview and using other people and informing adaptive profiles. in a minute. It's defined by typical performance, not ability. And what's wonderful about adaptive behavior is it's modifiable, meaning it can change over time and it can change quite quickly. And that's why it's a useful outcome measure, for example, in treatment studies and clinical trials. And it's one of the only things when you're doing an assessment that you're aiming to be completely adequate, just average. You don't want to strive to have high adaptive skills because, for example, you don't want these little girls who are, of preschool age going out in the community by themselves, driving a car and going on dates. So you don't really want to see high adaptive skills. And when you do, it really should be a red flag. Did something go on in administration that might have been wrong? Or is this person, for whatever reason, parentified? For example, you can see younger children doing all the daily living tasks in a household because they're caring for their parents. So to give you some history on adaptive behavior, Edgar Dahl was the first to develop a scale for adaptive behavior. It was called the Vineland Social Maturity Scale. And even though it focused on the construct of social competence, it really did look like the Vineland that we see today. It was more about communication and socialization and motor skills and daily living skills. But Edgar Dahl at the time knew that when you're in a clinical situation assessing for adaptive behavior, it's hard to assess with a person who has a disability themselves. It's also hard to see and observe adaptive skills in a very contrived clinical setting. So you really did need to conduct a clinical interview with a person who knows the individual very well. So a respondent such as a parent or caregiver. And when Sarah Sparrow updated the Vineland Social Maturity Scale in the late 70s and early 1980s, she kept true to the clinical interview, and the original Vineland was only an interview. It did not have the option of being a rating scale. The interview does help protect against if a parent is either consciously or not consciously trying to give an perception of their child, whether they want their child to look good or they want their child to look bad. An interview can protect against that. An interview can also protect against any parent after looking at tens, if not 100 different items of thinking, oh, can my kid do that? And they default to the can do rather than, oh, someone checking in and saying, oh, you just said your child can brush their teeth. About what percentage of the time are they brushing their teeth without you having to remind them, prompt them, support, or help them? That's a very different answer for some families. They say, oh, well, of course she can, but there's no way she does. I have to remind her all the time. Or is it a true deficit that, no, she actually can't, and she's, 8 years old, she should be able to, but she doesn't have that ability yet. So we want to assess adaptive behavior both in relation to one's chronological age, but also one's mental age. So the structure of the Vineland has communication, daily living, socialization, and motor domains, and then there are subdomains within each. The Vineland also has a maladaptive behavior index, so it's assessing for inappropriate behaviors or atypical behaviors that get in the way of functional daily living. And so that's just a basic screener to say, are there areas that you would probably want to further assess. So to look at the overall structure of the Vineland, for those of you who are less familiar, because the Vineland-3 has now been out for 4 years, but if you're less familiar with it, there are 3 versions. There's an interview form, there is a parent-caregiver form, which is like a rating scale, and then there's the teacher form, which is a rating scale. The comprehensive version of each is the original whole version. You're getting all of the domains and subdomains that you're assessing. But the Vineland-3 now has a briefer domain level version of each form that I would strongly suggest that you're only using for eligibility purposes. If you need your adaptive behavior assessment to inform treatment and intervention, I would use the comprehensive form because you're going to get a lot more information there. The Vineland is for ages birth through 90 plus. And depending on the version you're using, it could be 45 minutes to an hour for the interview and shorter for the rating scales. So because the Vineland is really the most widely used measure of adaptive behavior worldwide, in the field of autism, it has the most research on it. So we know about these adaptive profiles in autism quite well. We know that obviously it's a social disability, so the socialization area of the Vineland usually comes up lowest. We know that adaptive behavior usually falls substantially below cognition and age expectations. However, more recent research is showing that the gap between cognition and adaptive functioning really tends to depend on whether or not the person has intellectual disability or not. So those individuals with no cognitive impairment do tend to present with a wide gap between their cognitive potential and what they actually can do with independence versus those who have cognitive impairment. Interestingly, people with significant cognitive impairment, their adaptive behavior skills are usually on par with their mental age, if not higher. So to see a common profile on the Vineland for autism, this is a 9-year-old male with an above average full scale IQ. You can see that all of his standard scores are falling below not only his IQ, as they should because he's got above average, but also below his chronological age. Even the communication score of 81 is still lower than what would be expected based on his IQ. Now, within the communication domain, I want to highlight that in autism, you tend to see inflated written scores, meaning that that will be your highest subdomain because people with autism love numbers and letters and reading and writing. That's usually a skill that is easier for them, regardless of cognition, whereas receptive and expressive skills could be lower. Daily living skills, these really depend on the family, how much a family is doing for their child. And certainly if you have a child with a disability, the priority list and what's on the hierarchy, a lot of parents will just say, oh, I just dress my kids. So it's easier to get out of the house in the morning. However, in the socialization domain, you will tend to see interpersonal relationships be low, if not the lowest subdomain score, and coping skills, because this is behavioral regulation, which many individuals with autism have difficulties in behavioral regulation. So just to briefly go over the history of research that I've done on adaptive profiles, when I was at Yale, Ami Kalin, Sarah Sparrow, and I and our colleagues looked at only a sample of high IQ boys. So these were boys ages 8 to 18, and their full-scale IQ is that dotted line at 100. So solidly average cognition. But the colored boxes are their adaptive skills. Red is communication, green socialization, blue daily living. When you have discrepancies like that, you don't use the overall composite because that's averaging out highly variable scores. So you can see that the socialization score is falling more than 3 standard deviations below IQ. We were struck by that and contacted Kathy Lord, who was then at the University of Michigan, and analyzed her data and found the same profile. So these high IQ boys had significant adaptive deficits. We replicated this in a consortium study of over 1,000 individuals, both males and females. And what we wanted to look at is the gap between cognition and adaptive functioning, and whether or not older individuals presented with a wider gap than younger individuals. So if you look at the blue boxes all the way to the left, the full scale IQ, the blue box are the younger age cohort, 4 to 8 years, and then the green box is the older age cohort, 9 to 16 years. And you see their full scale IQ is very similar. There's no significant difference there. Yet when you look at adaptive domains, communication, socialization, and daily living, the younger group had higher adaptive skills than the older group, meaning the gap between cognition and adaptive functioning was wider in the older versus the younger individuals. That was not a longitudinal sample, so there could could have been cohort differences. So we wanted to look at this longitudinally. So at Yale, there was a study led by Kasia Havarska and Naomi Klin, where we did an initial diagnosis on toddlers at age 2, followed them up again at age 4, and then again at age 8. This graph that you're seeing is the children at age 8 who had no cognitive impairment at age 8. But you can see at age 2, their proxy, their developmental quotient by the Mullen scales was actually delayed. So they did have developmental delays at 2, but then by 4, they started to remediate those delays. And by age 8, their cognition was solidly average. What I want to show you here is the Vineland communication between 2 and 4. It goes very parallel with cognition. And this is important to know when we talk about remote assessments. If you are a clinician that's conducting remote assessments on children and you don't have a means of conducting a developmental assessment, using the Vineland as a proxy for communication at those young ages of 2 and 4, they're highly correlated. You see a gap go between functional communication and then rote communication later on, but in the younger ages, it's okay to use the Vineland as a proxy for communication skills. What this graph is showing that between the ages of 2 and 8, all adaptive skills are trailing behind cognitive development. So that gap is widening with age. However, when you look at the children at age 8 who did have cognitive impairment, and this was a much smaller sample, their adaptive skills were actually higher than their mental age. And then we looked at infants who were at high risk for autism by nature of being a biological sibling. So remember how I told you that siblings are much more likely to develop autism. So here, this was led by Jesse Bradshaw, who is now a professor at University of South Carolina. And we looked at the babies. We had the high-risk infants, but we had low-risk controls. If we look at the proxy of nonverbal cognition based on the Mullen, these are age equivalents, so you're going to see them increase. You see that the typically developing toddlers had actually above average nonverbal skills. Thankfully, their Vineland socialization or interpersonal skills were solidly average. Remember, we want those to be adequate, not above average. So we expect to see a parallel discrepancy here. With the high-risk infants that went on to develop autism, they also had above average nonverbal skills between the ages of 1 and 3 years, but their adaptive interpersonal skills start to trail behind prior to 36 months. And in fact, that's prior to when they were diagnosed with autism. So the delay in acquisition of functional interpersonal socialization skills is occurring in autism prior to even when the full-blown symptomatology is there. And I'd like to bring your attention to this article that came out of Australia last year, the misnomer of high-functioning autism, because when we use that term and we say high functioning, we are giving the impression that these individuals who have intact cognition and intact language are actually not in need of services. They are desperately in need of services. And many of you who've worked with these individuals know their social disability is debilitating in many areas of their life. So we really have to consider adaptive behavior quite strongly when we are determining how, quote unquote, functioning these individuals are. So when we look back at the spectrum here, I like to see it more about adaptive skills than cognition. And if we look on the left-hand side, when we identify individuals with significant cognitive impairment, I think we as clinicians are very good at saying, oh, let's teach adaptive skills to this person. Teach them how to dress themselves, teach them how to bathe, teach them how to have toileting skills, to feed themselves, to count change, to know calendar concepts, to, have basic vocational skills. We forget to do that, or we're not as good at doing that. When we have someone with average cognition or even superior cognition, to think, oh, we still have to teach that person to dress themselves, to groom, to have good hygiene, to have good personal care, to have vocational skills. So Moving on in the evaluation process, so that was the psychological component. Now find your trusted speech pathologists who are going to really look at the profile of speech, language, and communication. And what's nice is that when we developed the Vineland-3, we were really paying attention to all aspects of this language profile to get items that were functional into the Vineland that represented all of these areas, from just basic grammar and syntax all the way up to metalinguistic and perspective taking skills, theory of mind, sarcasm, things like that. And then the speech pathologists and certainly many clinicians are going to be assessing for the conversational reciprocity, the rules that go with not only you as the person with autism. What do I have to monitor? I have to monitor my eye gaze, all my nonverbals, my facial expressions, my gestures, then my speech and the tone of my voice. And then I also have to monitor all of this with my conversational partner. What does their eye contact mean? What do their gestures mean? When they're yawning, when they're looking at their watch, what does that mean? So these are the more subtle forms, the nuances of social communication that we still need to assess. And so that brings us to the diagnostic assessment. Now we are assessing for the symptoms of autism. So we can try and do this in the absence of cognition, development, and language, but then how are we going to know that diagnostic differential if not comorbidity? So I always tend to do those standardized assessments first before I delve into the autism symptomatology. And so for the nature of this webinar, I am just staying with the process of this diagnostic assessment, and I'm not going into detail on specific measures, just knowing that the process is twofold. Because autism is a neurodevelopmental disorder, we have to do a comprehensive history to see what symptoms were present in the first few years of life. So that is with a parent or caregiver. That is with somebody who knew that individual as a very young child, even if you're assessing an adult. And then I'm going to conduct the direct observation testing. And so I'll talk about this, just the process of it, but then the process of it in COVID times. How are we going to do direct observation of a social disability if it's remote or if it's in person wearing facial masks? So there are many ways to assess autism symptomatology. We have screeners, we have rating scales, and then we have direct assessment. And if there's one take-home message I want all of you to have, and if you've heard me present before, I say this ad nauseum, there is no measure that diagnoses autism. Clinicians diagnose autism. You diagnose autism with your expertise, your knowledge, all of your experience. That's how you assess and diagnose autism. That's a huge responsibility, and sometimes it comes as a burden when we don't really know. It's our judgment. How do we don't really have a clear litmus test to say, yes, we're right or wrong. So we will be right and wrong. And we just have to trust what experience and expertise we have. So there are many ways to do a developmental history. You can use semi-structured histories that are out there that are commercially available, or you can just follow a DSM checklist, or you can do a combination of both. I like to go through just developmental history first, and then I delve into the autism diagnostic criteria. So I just did a history this morning on a young child for autism. So starting with family history, is there anybody in the family that's biologically related to this child that had any developmental delays or concerns, speech delays, developmental delays, learning disabilities, autism, ADHD, anxiety, depression, schizophrenia? I'll go into the whole psychiatric history. I ask about the parents. I ask about the extended family, aunts, uncles, grandparents, cousins. And then I will do a whole birth history. How was the pregnancy? Any complications in the pregnancy? What about birth? What were the APGAR scores? Were there any complications at birth or hypoxia, prematurity? And then any birth complications? Was there a NICU stay? Was there a feeding issue? Was there, anything that happened that prolonged the hospitalization? And then those early developmental milestones, so motor milestones, speech milestones, social milestones, and then I go into behavior. I'll do medical history. I want to know about seizures. I want to know about any hospitalizations, any illnesses, and anything that might be out of the ordinary. And I tend to always ask about genetic testing. And then we go into educational and intervention history. And then I'll go into the diagnostic criteria. So really delve into social communication, interaction and play skills, restricted and repetitive and stereotyped behaviors. And then now it's time to do direct assessment with the individual. So you can do observations, you can do, report, but I personally want to be interacting, like in the room with the individual. Even with all of my years of supervision, if I were observing someone else assess a child and I felt unsure of the diagnostic presentation, I always would need to go into the room and just take some time, even just as a supervisor, to get that feel for the individual in person. So I'm going to assess those verbal and nonverbal communication skills, conversation, play, and interaction skills. I'm going to go into higher order perspective taking if it's a higher cognitive, higher language individual. Look at responsivity, reciprocity. Do they initiate or do they just respond? They're really good responders in autism. So if you're highly structured and you give a lot of supports, that child's going to look better and better. So always give yourself an opportunity to stop and wait for the initiation, right? So you drop a bid and you wait and be comfortable with that silence, because there will be silence. That's the nature of the disability. And then insight and awareness into one's social and emotional experiences, especially for older individuals who have higher cognitive and language levels. Ask them, have you had social experiences? What was that like? Did you have any role in that? Because a lot of times people will say, oh, yeah, I got in trouble at school, or I got, suspended or fired from my job. It's because so-and-so isn't accommodating. And there's very limited awareness of what that person might have done that helped deteriorate the interaction. And then you want to look for restricted, repetitive, and stereotyped behaviors. These are not always high frequency, which is, it can be problematic if you're just looking for these in a clinical setting. So you have to ask about them by parent report or teacher report or both. But if you know about them, probe for them. So if I know that someone has a circumscribed interest in Pokemon or in, Fortnite, I'm going to ask about it. And I'm going to get as engaged as they are in the topic. And really, so we get on topic, and now there's back and forth, because usually there can be reciprocity with the topic of one's interest. And then I will sharply and abruptly change the subject and see how easily they can transition away from their topic of interest. Look for fixation on objects and the visual peering. And so you might put things out in the environment to pull for those stereotyped behaviors. And then assessing play skills. So going back to the Vineland, in the socialization domain, there is a play and leisure section of the Vineland that really goes over these different developmental stages of play and has items in there that you can ask when the child was younger, did they do this? Because in typical development, we see in very young kids, infants, sensory exploratory play. This is mouthing everything, dropping everything, manipulating and feeling objects. And then it transitions to cause and effect play. So in toddlers and preschool age kids, they love push button everything, musical toys, pop-up toys. And then it goes into functional play. So you take toys and you play with them in their intended manner. Cars go on a racetrack. A toy phone goes to your ear. A baby doll goes in a carriage or in a crib. And then it goes into symbolic and imaginary play. I'm going to pretend that I am the superhero, or I'm going to pretend that this block is my car or my toy phone. In autism, you see extended sensory exploratory play. You see perseverative cause and effect play, the pushing of one button over and over and over again until it breaks. And you see impaired functional play. So rather than putting the car on the track, all the cars line up and they never actually do anything functional. They're just in a line, and very upsetting if you move them from the line. And then there's usually a deficit in symbolic and imaginary play. That tends to be more the case with boys. Girls with autism, and certainly the higher cognitive girls, they can go through symbolic and imaginary play, and in fact be quite creative in their play, which can mask some of their underlying social deficits. So that's something to pay attention to. Okay, so I went through that rather quickly, but I did want to get to the topic of how on earth are we doing this now in our COVID times. So let me just get out of the way right now. There was not any standardized assessment or semi-structured assessment that was normed via telehealth or with examiners wearing PPE, with face masks, face shields, using glass partitions. None of this was thought of when the majority of our tests on the planet were standardized. So that said, should we throw the baby out with the bathwater and just not do any assessments right now? Absolutely not. We have to move forward. We have to continue to help these individuals clinically. So we have to make some modifications. So if there's the second thing I can give to you as a take-home message is use your clinical judgment. You all are experts in your field. Trust your clinical judgment to determine whether or not whatever measure you're using remotely and or in person with PPE gave you a roughly valid estimate of whatever you're assessing. If so, that's the best we can do right now. And document it. Put in the report, yes, this evaluation was conducted with both the clinician and the child wearing facial masks. This cognitive assessment was not normed wearing PPE. However, the parent observed the entire assessment and corroborated that Johnny's performance was completely consistent with general expectations. For this reason, it is my clinical judgment that the results are a valid estimate. So just document everything. And if you think you didn't get a valid estimate, document that. You can always say right now, it's just too hard to tell. Let's revisit this in a few months, hopefully, and under less restrictions. We can get into a whole discussion about this. I know that this is challenging, both for determining eligibility in school systems and for getting reimbursement from insurance companies. Hopefully, there'll be some leniencies in that regard because this is our new normal and we're doing the best that we can. If you go to Pearson Assessments and go into their Telepractice site, you will see dozens of standardized assessments that Pearson has now offered for remote assessment. And the ones I circled here will show you that you can do a comprehensive battery of getting your cognitive profile or developmental profile, your language profile, and your adaptive profile. So you have enough information there to start your differential and or comorbid evaluation prior to getting to the autism symptomatology. So the fact that there are these many options out there for us, it's fantastic. Are they all completely valid and reliable? Of course not. Not everything out there was standardized in this manner. However, some research, we've already been in COVID for several months. And so some research is underway on this to say, actually, we do have data looking at the WISC-5, for example, being conducted remotely. And if you click on any one of these, you will get a host of information on how to administer that particular assessment via Telepractice. So let me just tell you something about the Vineland that happened to me today, and hopefully this can help alleviate some anxieties. So I've presented on the Vineland for years and years and years, and I will preach to the choir. If you're conducting the interview, it's the gold standard. The interview should be conducted in person. It's not supposed to be conducted over the phone. No one was ever thinking about Zoom and Skype or whatever. So how has that changed? This morning, I was doing a history, like I said, and I had scheduled the Zoom call to do both the diagnostic history and the Vineland interview via Zoom, so face-to-face, remotely face-to-face. The mom had difficulty accessing Zoom. We had to abort the Zoom option right on the spot. So I had to do everything by phone. And I had to make an in-the-moment decision. Am I going to forego the interview because it's on the phone and go to a rating scale, which is not my ideal because it's not, in my view, best practice? So I went with my judgment to give the interview by phone. And there were some challenges. I don't have nonverbals on which to go to help ease that the interaction for the rapport. So sometimes I had difficulty knowing if or meant yes or no. So I would have to ask the mom, I'm sorry, could you repeat that? Did you mean yes or no? And of course that kind of interfered with the flow of the interview. But overall, I got through the entire assessment, and in my expert clinical judgment, I feel I got a valid estimate of adaptive behavior. Was it my ideal? No. I'm doing the best that I can, right? So I, as an author of the Vineland, gave a phone Vineland. So the Vineland police, they'll have to come after me if they're coming after you, okay? Just wanted to alleviate those anxieties. And now what do you do about autism symptomatology? So let's start with remote options. You want to obviously have a HIPAA compliant telehealth service. So whatever is your preference that's HIPAA compliant. You want to give as many instructions to the parents or whoever is in the home, the facilitator, if you will, with the individual. You might even send a staff person to the home, depending on safety, depending on where you live, if that's even an option. But the facilitator can be a parent or caregiver. Just ahead of time, give them as many instructions as you can. I would want to watch or observe the individual in multiple settings. So I would give suggested activities and interactions and then say, okay, I want to spend 5 minutes doing this. And then we're going to stop and I want you to spend 10 minutes doing this. And then you're going to stop and do 5 minutes doing this. So I get a range of activities and maybe even people. Can dad come in the room? Can a sibling come in the room? And then depending on the age and level of functioning of the individual, I might ask them to just sit right across from me and I engage in an interview interaction with them. I'll tell you, as many of you know, how many Zoom calls you've been on for your respective jobs. It's very hard to determine eye contact via any remote device, right? If I'm looking at the camera right now, I might look like I'm looking at some of you, or I might look like I'm looking up to some of you. If I saw you in front of me and I'm looking at your eyes, it probably doesn't look like I'm looking at you via Skype. So eye contact, that is very challenging to see. But if I see that individual engaging with someone else and I just observe, I can so much easier to determine, is that naturalistic eye contact or not, integrated with their speech and gestures, etc. And so these are just the different options that you have. And then in person, I don't know how many of you in your respective states are back to seeing people in person. So I'm in the state of Georgia, and our state opened up earlier. So I have started conducting a hybrid. I will do the minimal amount of in-person that I feel is absolutely necessary to do a diagnostic evaluation, meaning my assessment of cognition and my diagnostic interview play session. And then I will do everything else remotely. If you look on the left picture, that's my waiting area. I will prop the front door open so that the family never has to touch a door when they walk into my office. I have everything there: masks, wipes, hand sanitizer, tissues. Then when we come into my testing room in the back, again, I have all doors open so no one ever has to touch a door handle. Then I will sit across from the child wearing a face mask. I ask that all individuals wear a face mask, and all parents. I ask that just one parent come. I have had more than one, but I can sit them back toward the end of the room so we're more than 6 feet apart. I will provide a metal, like a stainless steel stylus, as a pointer so that individuals who can follow instructions will point to my stimulus books with the pointer rather than use their fingers. I've seen some people will use a transparent sheet that they will put over every page of the book. So if a child just, wants to use their fingers and put and touch, they're touching the transparent sheet rather than the actual book. You can just wipe down the book as best you can when you're done. Providing individual pencils. If the individual uses a pencil, they just keep the pencil. If a parent is signing my consent form, they get to take home the pen. Or you can wipe them down as you go. And so that's the way I have navigated this. I will tell you that, for the most part, it's worked out well, and I have been confident in my diagnostic calls. On the occasion that I was unsure, because the PPE, it's interesting for those of you who've done it. You can see lots of facial expressions and eye contact and affect and tone of voice, even when someone's wearing a mask. But when someone's affect is restricted, in particular, this client had comorbid depression, it was hard for me to tell what was the social disability, restricted affect and restricted voice versus the depression. And so for the entire time I was doing the assessment, I was still on the fence to make that diagnostic call. So I didn't force myself to make that diagnostic call in the moment. Instead, when the family went back home, I scheduled a follow-up Zoom. And then on the Zoom, I could see the individual without a facial mask and have another interaction, and then compare to what my in-person experience was. And then I could more confidently tell, yes, this was an autism restriction rather than just solely depression, to help me make the diagnosis of autism. Okay, and just to end with, sanitize, sanitize, sanitize. Keep yourself healthy. Keep everyone that comes around you healthy. So Pearson has been nice enough to provide all of this information for you, that you don't have to reinvent the wheel. You can go on the website and see all of this. So with that, here's just a summary. The two main take-home messages is that you are, as a clinician, diagnose autism, and just please trust your clinical judgment in these COVID times. We're doing the best we can. We know that everything isn't going to be 100% valid. Just do with what you have as best you can. And finally, just be safe, please. And so with that, I am happy to open this up to questions. So thank you so much for your time and attention.
Thank you so much. As long as we're talking about attention, can you describe sticky attention for us, please?
Oh, sure. Sticky attention is perseveration. So when it's over-focused attention, when a child or an individual is so fixated on something, no matter how much you try to disengage them, call their name, get their attention to something else, they just are so over-focused, they don't shift.
Great, thank you. Another question came in about if you are suggesting that parents at preschool age attend the testing session from someone that said that they typically do not allow parents in the room.
Okay, so that's not in line with my typical practice. I have always, whether I was in an academic setting or now in private practice, always have a parent present, or at least give the individual who's older the choice to have the parent present. For young children, I need the parents' observations to tell me whether or not my results are consistent with general expectations. I wouldn't know that otherwise. I love when parents are sitting there going, oh my God, I never would have thought they'd know that. Or, oh, she's messing with you. She totally knows this and she's just, she's being stubborn or whatever. I need that information. And so I just personally always have had the parents in the room for very young children anyway. So it does make it harder when there are multiple parents coming in because I have a small space. And so it heightens the risk the more people that are present.
Great, thank you. We had another question come in about, have you asked parents to video their younger child playing or interacting with a sibling?
Yes, absolutely. So if you can't do that direct observation remotely into their home to see it, then video is the next best thing. So yes, I would say, upload it. And again, I would give the same instructions. Give me 5 minutes of a play activity, 5 minutes of a conversation, 5 minutes of eating, 5 minutes of dressing, so I get a range of behaviors.
Great, thank you. Are there types of autism that are marked by intellectual disability intrinsic to the autism, or is it normally considered comorbid?
Oh, that's a great and complex question. So right now, the current statistics are about 1/3 of individuals with autism will have intellectual disability when they're tested. The genetic comorbidities the genetic disorders associated with autism tend to have intellectual disability. So this is something that the child's likely innately coming into the world with impaired cognition. We have made great strides in the field with really early detection and early intervention that we can remediate many developmental delays, especially speech delays. So if it's verbal IQ that's lower when they're very young, that sometimes can be more easily remediated than conceptual delays, nonverbal delays. That's not to say you can't increase nonverbal IQ. You can teach how to, teach learning readiness skills that enhance overall cognition, but some people are just innately more impaired neurologically.
Great, thank you. Do you have any opinions on the speculation that women and girls are better at masking?
So this idea of masking, camouflaging symptoms is really big in the literature for females with autism. That's not to say that males can't mask. They certainly can as well. But I think females just, historically are more social and more verbal, that reciprocity, that social motivation, and the verbosity tends to just in and of itself mask, because people think, oh, that's not classic autism. If they're trying to interact with you, if they're reciprocating interaction, if they're actually sustaining some interactions, that can't be autism, when in fact it absolutely can. Great,
thank you. With adaptive behavior being modifiable, is it possible that defects in adaptive behavior are themselves a result of extrinsic socioeconomic or social development, such as a result of a parenting style?
Oh, so autism is a social disability and a neurodevelopmental disorder. So you're seeing the disability emerge very, very early in life. First 2 years of life, you're going to see those social impairments emerge. If we're talking about something like neglect, like severe parental neglect, in orphanage research, for example, those young children did present like they had autism, but when they were in a more nurturing environment, many of those symptoms subsided over time. So can that happen? There be a misdiagnosis? Yes, but it wasn't autism to begin with. It was a misdiagnosis of autism. So do I think autism can be caused by parenting styles. No.
Great, thank you. I know we're almost out of time here, and I don't want to have us get cut off or anything, but I just wanted to thank you again for your time today, for sharing this. We've got additional questions that we'll attempt to follow up with via email, but thank you everyone for attending. Thank you, Dr. Saulnier, for sharing all this great information with us. We really do appreciate your time.
You're welcome, and my email's right there, so people can feel free to email me as well if their questions were not answered.
Great. Thank you so much.
All right. Thank you. Take care, everyone.
Thanks. You too. Bye-bye.